As of March 6th, 2020, so in just the first 3 months of the outbreak, there have been 100,685 cases of COVID 19 and 3,411 deaths. That works out to a mortality rate of 3.4%. On top of that, every case of COVID 19 leads to roughly 2.3 new cases, meaning that the outbreak is still spreading. Many countries have been affected, and there are numerous cases of community spread, meaning that individuals are getting sick without being around any sick contacts or having traveled to outbreak areas. In that context, healthcare workers need a diagnostic tool for COVID 19 that's highly sensitive. In other words, a tool that allows them to catch almost every single case. The gold standard for diagnosis of COVID 19 is RT-PCR, or reverse transcription polymerase chain reaction. But here's the problem. Current data suggests that RT-PCR is initially only 30 to 70% sensitive for acute infection. In other words, 3 to 7 out of every 10 patients that actually have COVID 19 will have a negative PCR result. There could be many reasons for this. Perhaps early in the disease there is not enough virus in the blood for detection, or perhaps the lab kits weren't being correctly used. However, the largest study to date of over 1,000 patients showed chest CT has an initial sensitivity of over 95%, meaning that less than 1 out of every 20 cases would get missed. That has massive implications because far fewer people with COVID 19 would get sent back home where they can get sicker and spread the disease to others. Now, the RT-PCR test may improve over time, but it's clear that chest CT has higher sensitivity early on in the disease for patients sick enough to present to hospital settings in China. This strongly suggests that chest CT can be used to identify patients that need further testing, as well as for isolation and to help inform treatment. This is especially relevant in settings with good access to CT technology but poor access to reliable laboratory testing, or in situations where centralized public health laboratory tests have a turnaround of many hours or days. Typically, when a patient has symptoms of COVID 19, like fever, cough, or shortness of breath, they may get a chest x ray. Because they're cheaper and easier to do than CTs, they're often done first. The most common abnormal finding is ground glass opacities, meaning that some portions of the lungs look like a hazy shade of gray instead of being black with fine white lung markings for blood vessels. It looks a little bit like frosted glass, like a window in the wintertime. It is important to note, however, that chest x-rays are not very sensitive for COVID 19, and that patients who are highly suspicious for COVID 19 viral pneumonia should probably get a chest CT even if their initial chest x-ray is negative. Now, compared to chest x-rays, chest CT gives a much more detailed view. The most common CT finding in COVID 19 are those ground glass opacities scattered throughout the lungs. They represent tiny air sacs, or alveoli getting filled with fluid, and turning a shade of gray on CT scans. In severe or more advanced infections, more and more fluid will accumulate in the lobes of the lungs, so the ground glass appearance will progress to a solid white consolidation. Finally, there's a finding called the crazy paving pattern due to swelling of the interstitial space along the walls of the lung lobules. This makes the walls look thicker, like white lines against the hazy ground glass background. The appearance is similar to irregular-shaped stones used to pave a street, hence the name crazy paving. These 3 CT findings, ground glass opacities, consolidation, and crazy paving patterns, can be seen in isolation or in combination with one another. Ground glass is usually the first sign and is followed later by one or both of the others. These findings usually occur in multiple lobes throughout both lungs, and more commonly affect the outermost or periphery of the lungs. Having said that, in mild or recovering cases of COVID-19, the findings can be isolated to just one lobe. It's no surprise, then, that disease severity is proportionate to the lung findings. The sickest individuals typically have the most severe findings on chest CT, and as patients improve, there's gradual resolution of the ground glass and consolidations. Now, it's worth mentioning that there are some key CT findings that are typically absent in COVID-19. You don't usually see pleural effusions, which are fluid collections in the pleural space right outside the lungs. These are more common in conditions like congestive heart failure and bacterial pneumonia. You also don't see large lymph nodes in the mediastinum or near the hilum, or central part of the lung, which are often seen in other types of pneumonia. Finally, you don't typically see lung cavities, which usually develop in bacterial and fungal pneumonia due to necrosis of the lung tissue later turning into an air-filled cavity. Now, even though a chest CT is very sensitive for COVID-19, the key findings, ground glass opacities, consolidations, and crazy paving, can also be seen with other causes of viral pneumonia, like influenza and adenovirus. They can also be seen in a variety of non-infectious conditions. That means that chest CT is sensitive, but not very specific for COVID-19, and that individuals with these findings should get thorough testing done. A number of countries have been isolating patients with classic CT findings until laboratory tests help identify the cause of the disease, and then they can be properly treated. Lastly, it's important to recognize that the role of CT in evaluation of patients will depend on the severity of infection in that patient, as well as the prevalence of COVID-19 in that community. In individuals who are asymptomatic or have really mild disease, the sensitivity of chest CT falls to about 50% if it's done in the first 48 hours of symptoms. In other words, individuals with very mild disease may eventually have positive RT-PCR results, but that would have been missed by an early chest CT scan. Also, chest CT is less useful as a screening tool in areas where there's very little circulating COVID-19 because the findings are more likely due to other causes. On the other hand, chest CT is most useful in patients who are acutely ill and symptomatic in areas with a high burden of COVID-19 disease, similar to the situation in the initial outbreak in China. In this scenario, patients with classic CT patterns of COVID-19 and no other explanation for these findings should be treated as presumptive infections even if their initial RT-PCR test is negative. The higher the prevalence is in a given area, the more likely it is that the highly sensitive but non-specific CT findings represent a true case of COVID-19 that will eventually turn positive on RT-PCR. Alright, as a quick recap. In early COVID-19 disease, chest CT showed a much higher sensitivity than RT-PCR for the initial stages of the disease in hospitalized patients, although this may change as the RT-PCR test is improved. The key findings on chest CT include ground glass opacities, consolidations, and crazy paving. Individuals presenting to hospitals with these chest CT findings may need isolation and should get thorough confirmatory testing and appropriate treatment. Lastly, follow-up CT scans can help monitor disease progression and recovery.